Welcome back to our next session of this patient-focused drug development meeting. It's my honor to introduce our next speaker, Dr. Melena Bellin from the University of Minnesota. Melena is neither a gastroenterologist nor a surgeon, but she's become absolutely expert in the treatment of pancreatic disease, and particular pancreatic diseases in children. She's a pediatric endocrinologist who also happens to have a joint appointment in the Department of Surgery because she leads the research program in total pancreatectomy and islet autotransplantation. You've already heard about this from many of the patients who've spoken already today, but Melena is going to give you her perspective as she sees many, many patients, only a few of which are candidates for this surgery. Dr. Bellin.
Thank you. Well, it's really an honor to be here today. I have had about 14 years of opportunity to work with patients who have recurrent acute or chronic pancreatitis, and I think they're a very inspiring group, so I'm really honored to be able to present with them today. So I'm going to focus on pancreatitis as it pertains to children. I think what we heard statistically earlier this morning is about 40% of the attendees at this conference had onset of symptoms in childhood. So obviously this is an important pediatric disease as well as an adult disease. So when we're talking about pancreatitis in children, it's really a long spectrum of what we see in adult disease, but there are some unique features in children. So first of all, what causes pancreatitis in children? Well, most of the data I'm going to talk to you about today comes from what we call INSPIRE. It's a study group for pediatric pancreatitis that was started by Dr. Aaliyah Uch and Dr. Mark Lowe about a decade ago. And so we know from now studying kids across the US and internationally who have pancreatitis that about 50 to 75% of them, depending on whether you're talking about recurrent acute or chronic pancreatitis, will actually have a genetic risk factor. I don't have all the genetic risk factors listed on this slide, but the main ones have to do with either a problem in the trypsinogen, trypsin pathway, in which trypsin becomes abnormally activated within the pancreas and causes inflammation, or a ductal problem, like a problem with the cystic fibrosis gene or the CFTR gene that prevents abnormally mediates bicarb secretion from the pancreatic duct, so you can get some sludging, obstruction. Now, I should say that genetic risk factors aren't mutually exclusive to other risk factors, so we actually see a number of kids who have more than one risk factor for disease, but about a third of the kids we see in INSPIRE have some sort of obstruction, usually a congenital malformation of the pancreatic duct, like pancreas divisium, either alone or in combination with genetic risk factors. And sometimes in this population, we see toxic exposures like medications that precipitated acute pancreatitis, hypertriglyceridemia, not typically things like alcohol that you might think of with some adult patients with pancreatitis, but really, primarily you're talking about genetic disease and congenital anatomic disease in this population. For a few, we never find a cause, and we call them idiopathic chronic pancreatitis. So these patients, these children who have chronic pancreatitis or recurrent acute pancreatitis have both acute symptoms and complications of disease and long-term risks from the disease. And I think the feature that comes out most often when patients come to clinic is complaints of abdominal pain. This can be episodic, it can be constant, it can be both, some constant pain with episodic flares, and it is very severe pain. I think that was reflected very well in the adult panel this morning. Oftentimes, this pain may need opioid medications for treatment when it's very severe. Unfortunately, pain may go undertreated because particularly in today's culture with worry about opioid abuse, and now you're talking about children, there can be some reluctance of pediatric providers to prescribe opioid pain medications even when the pain is severe. And then this is all in the setting of also nausea, vomiting that I think you heard a little bit about earlier this morning. The symptoms of recurrent pain certainly interfere with normal life. I think you'll hear that better from the panel than from me. But statistically, when we look at patients in INSPIRE, they're frequently hospitalized. If we look at patients who have recurrent acute or chronic pancreatitis, they have an average of about 2 ED visits per year and 1 hospitalization per year. But some patients are very severely affected and have dozens of hospitalizations. As you might imagine, that can interfere with normal childhood and going to school. So on average, children who have recurrent acute or chronic pancreatitis miss 2 or 3 days of school per month. But some patients are unable to even attend regular school. They miss so many days that the school says you have to do homebound school because they're not able to attend often enough. I hear families say very often to me, I think this is hard data, objective data to collect, but they will say, we can't plan a vacation. We're afraid of planning for this child to go off to college because we just don't know what the future is going to hold when they're going to have an attack of acute pancreatitis. And I think we heard a lot about psychological impact of this kind of chronic disease state. Naturally, if you're having pain, you're being hospitalized, you're missing school, this can also be associated with depression, anxiety, because you don't know when this severe pain is going to come up. That can lead to social isolation because you're not at school, and then that just makes depression worse. So you have this whole psychological impact of the disease state. Now, long term, these patients, because they get progressive fibrosis through the pancreas with chronic pancreatitis, so in other words, scarring through the pancreas, are at risk for losing the functionality of the pancreas. And if we look at kids during childhood and Inspire, about 1/3 of them have digestive problems with exocrine pancreatic insufficiency, and 6% have diabetes. But of course, those risks increase lifelong. So those kids with chronic pancreatitis are invariably going to become adults with chronic pancreatitis who are going to have more and more increased risk of diabetes and exocrine insufficiency as adults. So what can we do right now to treat kids with chronic pancreatitis or recurrent acute pancreatitis? And I think the reason that we're here is that our treatments, although we can offer treatments, none of them are that great, and none of them stop or just cure the disease. So we can offer a number of medical treatments, but they're really directed at symptom management more than anything else. So when these patients have episodes of pain, we can give them pain medications, non-opioid pain medications, opioid pain medications. For the complications like dehydration, you can treat them with IV fluids. For chronic pain, we really encourage a comprehensive pain management program that can be geographically challenging to find, but a good pain management program has ongoing care with both pharmacologic and non-pharmacologic aspects to pain management, health psychology, physical therapy. And then there's some treatments that might or might not decrease pancreatic stimulation and reduce attacks. We hear a little bit about diet restriction in adults and fat restriction. There's a lot of controversy about that, I would say, in children, and many providers would advocate not to restrict fat too heavily in children because they need that. They're growing, so they need their nutrients, including their essential fatty acids. You can give feeds and kind of bypass the pancreas by doing enteral feeds or jejunal tube feeds where the food is actually going past the point where the pancreas is to try to decrease that theoretic pancreatic stimulation. And pancreatic enzymes might be used for malabsorption, but they might also be used to try to calm down or suppress the pancreas. They're definitely effective for malabsorption. Whether or not they're effective to actually suppress the pancreas, I think, is debatable. There are some trials with antioxidants in adults just to calm pancreatic inflammation. They're of mixed results, and they haven't been tried in children. So we have a lot of medical treatments we can offer to treat symptoms of disease, but not so clear that any of them actually prevent disease or reduce episodes of disease. So for kids who really are having a lot of symptoms on medical treatment, we might consider stepping up to something that is a procedure or a surgery. And really the main procedure, non-surgical procedure that would be done in pediatrics is an ERCP, endoscopic retrograde cholangiopancreatography, as a treatment to try to remove any pancreatic duct stones or treat any strictures. Unfortunately, if a patient has strictures all the way through the pancreas duct, this starts to become ineffective. And some patients have recurrent acute pancreatitis with no stones, no strictures, and an ERCP probably isn't going to be very effective in that circumstance. So while it may help some people, it doesn't necessarily halt the disease, and recurrence may still be a frequent complication. So the other thing we can do is pancreas surgery. There are different ways you can do pancreas surgery. You can do a Whipple, which we heard about. You can do a procedure like a Pusteau or a Fry that basically open up the pancreatic duct. But we don't really do a lot of those in children these days, mainly because children usually have genetic forms of disease, and we think there's a high rate of recurrence with those sort of what we might call lesser type of surgeries. So usually the surgical approach for these kids, if they get to the point of severe disease where they need surgery, is to do that total pancreatectomy with islet autotransplant that you heard about. And that is a really extreme procedure. It can be very effective at treating pain, yes, but it involves a lot, both in terms of the surgery and the long-term complications. So the surgery itself involves removing the pancreas, and because of the blood supply, removing the duodenum, a little piece of the small intestine, putting the intestine back together, and usually removing the spleen. So you're talking about quite a significant and involved surgery process, and you have exocrine insufficiency always after that procedure, and usually some form of diabetes. So what are the barriers that I see to treatment in children other than having few treatment options? The other thing that I see patients complaining about, and patients probably can speak to this much better than I can, but pediatric pancreatitis is not a common thing to show up, say, in the community ER. So if you're at a place where there aren't providers, if they're primarily adult providers, they haven't seen pancreatitis in children. Even with a family history of disease, I've seen parents bring their kids in saying, I think this is pancreatitis, and are told, well, children don't get pancreatitis. We don't need to test for that because children don't get pancreatitis. So it can lead to some delays in diagnosis, and especially if you have no family history and no one's thinking of pancreatitis. When kids get to the stage of chronic pancreatitis, they can have chronic pain without enzymes going up. So another thing that people will do is they'll come into the ER and they'll be told, well, we checked your labs, your lipase is fine, this isn't pancreatitis pain. And that's not necessarily true, of course. There is kind of the stigma that we've heard about in adults. If you have a teenager that goes in, well, are you sure they weren't, drinking alcohol, or he or she, your child, probably just wants pain medications, they're probably just drug seeking. And there's the, especially if you have chronic disease and you're in the clinic, well, you look really good. You don't look like a sick person, so you don't look like you're in pain. So I think all of those are hurdles that I hear my patients saying, this is where it's really tough sometimes for us to get care, unless it's a provider who knows me and they've set me up with the infusion center and I'm not going to the ED, but going to a new provider can be really challenging. And for pediatric pancreatitis, I think really since I started in this field, I've seen so many gastroenterologists who have developed, pediatric gastroenterologists, develop an interest in pancreatitis, but they're still at academic medical centers. They're still geographically sparse. If you are a patient who doesn't live by a center that cares for children with chronic pancreatitis, it can be really a financial and geographic burden to get to a place that can provide appropriate care. And finally, to set the session of treatments for pancreatitis, for recurrent acute or chronic pancreatitis, I just want to summarize by saying that the options I talked about are really to either treat the symptoms or remove the pancreas to treat the pain. And neither of these, I hope, are the end-all of pancreatitis treatment, because all of these treatments are associated with lifelong morbidities. Either you're treating symptoms and the disease persists and progresses, or you're talking about removing the pancreas, which might treat the pancreatitis pain, but obviously still carries some lifelong implications in terms of exocrine insufficiency and diabetes. So with that, I will turn it over to our panel.